Hi all, my name is Katherine Philpott and I'm the Transfusion Laboratory Manager at Addenbrooke's in Cambridge. I'm going to give you this presentation on the topic blood groups and antibodies in pregnancy. Next slide, please. Okay, just before I start, I just want to say that if you're a BMS or already have some knowledge of blood groups and you haven't had your morning coffee this morning, this may be your opportunity to just go and grab it, as there's nothing new in this presentation. But if you want to stay, obviously stay. Anyway, for those that are staying, I intend to give you a guide through this presentation by taking you on a journey through the tests performed in the transfusion lab for pregnant women. As I expect you all know, blood group and antibody status of a pregnant woman should be tested at booking and at 28 weeks gestation to identify the ABO blood group and D status of the mother and to detect red cell antibodies that have the potential to cause hemolytic disease of the newborn and fetus. The hope is that as we go through this presentation, I'll be able to do the following. I'll be able to define the terms blood groups and antibodies, introduce some important blood group systems, outline the mechanisms that lead to antibody production in the mother, explain the properties of blood group antibodies with respect to HDFN, outline the purpose and process of antenatal screening in the UK, and how we identify and monitor antibody levels when a patient is at risk of HDFN. Next slide, please. Okay, first things first though, we need to have a basic understanding of the terms antigen and antibody. An antigen is a substance that is capable of stimulating an immune response. In general, two types of antigens are recognised, self or foreign or non-self, and self-antigens. Self-antigens originate within the body, whereas foreign antigens originate from outside the body. Examples include substances produced by viruses or microorganisms, substances in snake venom, not that we see that very often, proteins in food and components of serum and blood group, red blood cells from other individuals. Normally, the body is able to distinguish self from non-self, and antigens that are not recognised as self can stimulate the production of antibodies. Next slide, please. Okay. Therefore, an antibody is a protective protein produced by the immune system in response to foreign antigens. Antibodies recognise and latch onto antigens to remove them from the body. At the tip of each antibody, there are two antigen binding sites. Antibodies will generally only bind to a specific antigen that it was produced against to enable its destruction. Okay, thank you. Next one. Okay, with those definitions out of the way, the first test that we perform on the blood sample that you send us to the laboratory is the ABO blood group. Okay, next slide. So what are blood groups? A person's blood group is identified by antigens found on red cells within the blood. Red cell antigens are normally carbohydrate or protein structures found on the surface of red cells. This is a diagram here that shows a red cell depicting various blood group antigens as proteins or carbohydrates stuck onto or within the red cell membrane. Okay, there are now 41 formally registered blood group systems comprising of, comprising of over 300 different antigens. 9 of the 41 blood group systems are considered to be major systems. The ones you'll have probably heard of are ABO and RH, but may have come across some others such as MNS, P1PK, Lutheran, Kell, Lewis, Duffy and Kidd. A person's blood group is determined by the inheritance of different blood group genes, which result in the expression of different blood group antigens on the red cell surface. Next slide, please. So the ABO blood group system. There are 4 main blood groups defined by the ABO system. We have group A, which express the A antigen. If you could point to this one, that'd be good for me. The A blood group, which expresses the A antigen and produces anti-B. We have the blood group B, which expresses the B antigen and produces the anti-A. We have group AB, which expresses the A and the B antigen and doesn't produce any ABO antibodies. And then we have group O, which doesn't produce any antigens on the red cell surface or ABO antigens on the red cell surface, but does produce anti-AB. Thank you very much. The distribution of the ABO groups in the UK is around 45% Group A, 43% Group O, 9% B, and 3% AB, though this varies slightly in different parts of the country. For example, in the south of the UK, there are slightly more Group A individuals, and in the north of the country, there's slightly more Group O individuals. This distribution differs significantly around the world. Levels of Group B, for example, are seen more in Asia, with more Group O in Africa, in Native Americans, and Australians. Thank you. Okay, inheritance. As I've said before, ABO genes are inherited by simple genetics. What we need to know is that the A and B genes are co-dominant, whereas the O gene is recessive. So what we end up is with 4 phenotypes. The A phenotype results from the genotypes AA, where you get an A gene from each parent, or AO, where you get an A gene from one parent and an O from the other. The B phenotype results from the genotypes BB and BO, the AB phenotype from the genotype AB, and the O phenotype from the genotype OO. Okay, for example, when mother is Group A and the father is Group B, as shown here, it's possible for their children to be any of the ABO blood types, particularly if the genotypes for the mother, for example, are AO and the father's BO. It could be the other way around, but we'll take this for this instance. The child can therefore be Group AB, where the A gene comes from the mother and the B gene from the father. Sorry, can I get you just to point to these for me? Yeah, that's it, lovely. The child could be Group A, where the A gene comes from the mother and the O from the father. There could be Group B, where the B comes from the father and the O from the mother. Or there could be Group O, where we get an O gene from both mother and father. Okay, thank you very much. Just want to digress a little bit here and talk about antibodies, as they're important when determining a patient's ABO blood group. So blood group antibodies are produced in response to exposure to foreign or non-self environmental or red cell antigens. Environmental antigens are things like chemical structures identical to some blood group antigens, which are common in nature. These can be presented on the surface of bacteria and in some foods. Antibodies to the A and B antigens of the ABO system, anti-A, anti-B and anti-AB, are produced in response to our environment generally. ABO antibodies are referred to as naturally occurring, as they are produced without requiring stimulation from foreign red cells. They're usually developed around 6 months after birth, when an infant is starting to eat solid foods. Red cell antigens from one person may be introduced into the circulation of another by transfusion of allogeneic red cells, by pregnancy, and by transplantation. Thank you very much. In diagrammatic form then, if a patient is negative for an antigen, say they're D negative in this instance, who is given a unit of blood which contains the D antigen, so a D positive red cell, they have the transfusion, which contains, as I say, the D antigen, and their immune system can then recognise the D antigen as foreign and start to produce anti-D. Thank you. And likewise, where a mother who is D antigen, again, who again is D antigen negative, so D negative, is carrying a baby who is D positive, if there is a fetal maternal hemorrhage, even a very small one, then the mother's immune system can recognise the D antigen on the fetal cells as foreign and start to produce anti-D. Okay, thank you. So back to ABO. Knowing what we know about ABO, we now know that if receiving blood from the wrong ABO blood group can be life-threatening. For example, if somebody with Group B blood is given Group A blood, their anti-A antibodies will attack the A cells and destroy them, and vice versa. So if somebody was given Group A blood and they're Group B, they will destroy those red cells. Group O red cells do not have any A or B antigens, therefore it can generally be given safely to anybody. The table here shows what blood can be transfused safely to who, and in particular, this is what we would use for a woman of childbearing potential. just leave that there for a second. So the next test that we perform in collaboration with the ABO blood group is the D status. It's a D typing. Okay, thank you. Okay, we're wondering why there's a monkey there now. In understanding the D status, we need to know a little about the RH blood group system. That's RH, not rhesus. I know lots of people still call it rhesus, but it's RH. Rhesus are actually the type of monkey, so the monkey in the picture, and they were first used in experiments with red cells to produce anti-D. Okay, so RH blood group system comprises over 50 antigens, and the 5 major ones are D, big C, little c, big E, and little e. Okay. The D antigen is found in around 85% of the Caucasian population, with around 15% the D negative. In many other ethnic backgrounds, the percentage of D positive individuals is usually higher. Individuals who are D negative and transfuse with D positive blood or have a D positive baby quite often develop anti-D antibodies. It's thought that exposure to D positive red cells in healthy individuals would actually result in the production of antibodies in around 80% of cases. Although we obviously don't see this as much in hospitalized patients, and many patients are already immunocompromised when they come into hospital. This immunogenicity to the D antigen is thought to be in part due to the fact that the D antigen, which is embedded in the red cell membrane, as shown in the picture below, in D positive individuals, is unusually large compared to other antigens. It's just not there at all in D negative individuals, rendering these individuals susceptible to an immediate immune response if the antigen is encountered. Thank you very much. The D gene is again inherited by simple genetics. Where a person is D positive, they may have 1 or 2 D genes. Just to note that the absence of the D gene is denoted by little d. There is no such thing as a little d, but we just use little d to just identify patients who are D negative. Where each parent has 1 D gene, as shown here, then in 3 out of 4 cases, the child will be D positive. D negative comes about if no D genes are inherited. Thank you. As I've said before, 85% of people are D positive. This gives rise to the frequencies seen here of all the blood group frequencies encountered in the UK. As you can see, there is a definite variation depending on the country the person is from in the UK. I'll just leave that there on the screen for a second. Okay, moving on. Now we're going to take a look at the red cell antibodies that we search for in the laboratory to identify pregnancies at risk of HDFN. Thank you. So where do maternal antibodies come from? Antibodies are usually stimulated by a fetal maternal hemorrhage, where antigens on fetal cells can enter the maternal circulation and stimulate an immune response, or by transfusion of antigen positive cells to which the recipient is antigen negative. Some of these antibodies, and for those of you that are interested, they must be IgG class 1 or 3. These can cross the placenta, which can lead to maternal antibody in the fetal circulation. Once there, it can bind to the antigen positive red cells, which are then destroyed by the fetal immune system. So what blood groups cause HDFN? In general, any antibody that is active at 37 degrees is potentially capable of causing HDFN. Next slide, please. Anti-D, anti-little c, and anti-K are the antibody specificities that are known to cause severe HDFN and are therefore the most clinically important. They're the ones that we have to look for more so than any other. If identified during pregnancy, they must be monitored throughout to allow proper intervention and management to reduce the potential for HDFN. Both anti-D and little c are capable of in vivo red cell destruction, whereas anti-K suppresses the production of red cells as well as destroys mature red cells. This can lead to anemia without excess bilirubin being produced. All these antibodies must be measured throughout the pregnancy, every 4 weeks until 28 weeks, and then every 2 weeks until delivery. The possibility of HDFN due to anti-D and little c depends on the quantitation. There is a high risk of HDFN when the anti-D quantitation is greater than 15 international units and anti-C when the level is greater than 20. Thank you. Aside from anti-D, little c and K, other antibody specificities active at 37 degrees are also capable of causing mild to moderate HDFN. These include antibodies such as anti-big E, anti-big C and anti-little e of the Rh system, anti-Duffy A and anti-Duffy B, FYA and B, anti-JK A and B, anti-M, anti-S and anti-little s. Management of these pregnancies is assessed on a case-by-case basis, usually depending on the antibody titer. Besides anti-D and anti-little c, all other blood group antibody strengths are measured by titration of the antibody. Generally, the possibility of HDFN correlates with a titration of greater than 32, except for anti-Kel or Kel system antibodies, which can cause severe HDFN regardless of the titer. Thank you. So what about ABO antibodies, since they're present in all individuals except blood group AB? Well, despite the common occurrence of anti-A and anti-B, HDFN due to these antibodies is actually very rare. This is caused by some protective features, namely that the A and B antigen expression in the developing fetus are weak. Therefore, there is very little antigen available for the antibodies to actually bind to. The antibodies themselves are too large to cross the placenta. They're mostly what's known as IgM antibodies, and as shown below are considerably larger than the normal IgG antibodies, which are shown next to it. Additionally, many cells and tissues in the body actually also express A and B antibodies, so effectively mop up the maternal antibody. Therefore, it can do no harm to the red cells before it can do harm. Although rare, HDFN due to ABO antibodies can actually occur in group O women carrying an A or a B fetus. This is because group O people can produce a high level of IgG anti-AB. So what else can we do to help prevent or manage pregnancies at risk of HDFN? To prevent the production of anti-D and anti-K, red cell antibodies, and in particular in females of childbearing potential, we always transfuse conservatively where we can. And when required, D negative blood will always be given to a D negative woman, and K negative blood is usually always provided. During pregnancy, women who are D negative will at most hospitals these days be offered a cell-free fetal DNA test and or given anti-D prophylaxis as required. Next slide, please. So what's the cell-free fetal DNA testing? I'm not going to talk about this much because I know it's in the programme a bit further on. During pregnancy, a small amount of cell-free fetal DNA is present in the maternal blood. This DNA can be analysed to predict the baby's D group status. This non-invasive test is highly accurate and can be performed from 11 weeks gestation. Where the fetus is predicted to be D negative, anti-D prophylaxis does not need to be given, thus preventing unnecessary administration of anti-D. Prior to this testing being offered, around 40% of women received anti-D unnecessarily when they didn't actually need it. It's also prevented a lot of unnecessary testing, including very expensive antibody quantitations and FMH tests. Thank you. Where cell-free fetal DNA testing has not or cannot be performed, or where the fetus is predicted to be D positive, a prophylaxis regime must be followed. Generally, for potentially sensitizing events at less than 28 weeks, 250 international units of anti-D should be given, and at greater than 20 weeks, at least 500 international units, followed by a test to measure the FMH should be performed, or to test the fetal maternal hemorrhage bleed should be performed. Routine antenatal anti-D prophylaxis should be given in a single dose. We usually give 1,500 international units at 28 weeks, or 2 doses of 500 at both 28 and 34 weeks. And a dose of at least 500 international units of anti-D should be given at delivery if the baby is D positive. A fetal maternal hemorrhage assessment should also be performed. And just to note here that anti-D prophylaxis should never be administered to patients with immune anti-D. Thank you very much. To support the management of a pregnancy at risk of HDFN, where clinically significant antibodies have been identified, we can do various tests to determine the antigen status of the baby, since the fetus is only at risk of HDFN if the baby is actually antigen positive. This information can be gained from performing paternal testing and paternal red cell phenotyping to determine whether the father has actually got the corresponding antigen, which he could then pass on to his child. And just to note here, that paternal phenotyping should only be performed, obviously, on the paternal father, on the biological father. Alternatively, in some cases, we can now do fetal genotyping, which can be performed to detect antigen status of the baby. We can do this to detect the status of RHD, big C, little c, big E, little e, and K. Thank you. Following delivery, further tests can be performed to help determine the severity of the HDFN. This includes a cord blood sample, which can be collected for hemoglobin and bilirubin measurements, which can be monitored for several days after birth. And where we see a hemoglobin or a drop in hemoglobin and a steady rise in bilirubin, this can indicate the red cell destruction in the neonate. The baby's OVO type and D status should also be performed, as well as a DAT to look for hemolysis. A red cell phenotype can also be done to see if the baby has antigens to which the mother has the antibody. Thank you. Okay, this is a rather busy slide, but it is the last one, so we're nearly there. I just want to leave you with a small plea from the transfusion laboratory. Some blood group interpretations can be extremely difficult, especially when determining whether the anti-D is immune or whether it's identified because of prophylaxis. Therefore, it's important that all clinical staff, all of you, can maintain a clear record of prophylactic anti-D given, the dose and the date. We also would like to see this record on the request forms whenever you send samples to the laboratory. It's vital to take the 28-week sample for group and antibody screen before giving routine anti-D prophylaxis. Otherwise, all we're doing is testing, and all we'll find is the prophylaxis that you've given. And if immune anti-D is present, do not give anti-D prophylaxis as well, as this is regarded as giving an unnecessary blood product and has to be reported externally. If, on the other hand, interpretation of results is in doubt, always give anti-D, as this may prevent HDFN. Finally, if further samples have to be requested, please try and send them ASAP, because without them we could miss catching an antibody that is increasing to a dangerous level. And in return, the lab will aim to identify and quantify any antibody found and provide a statement of the likely clinical significance with respect to HDFN. We will always give advice on further anti-D prophylaxis based on the history provided and results obtained, and we will always request further samples at stated times to monitor the level of the antibody found. Thank you very much.